Alrighty. Hi, my name is Izzy. I'll be going through Resp, ENT, and Opthal, so three very big topics. So grab your coffees, grab your waters. If at any point you need to pause, please do so. And you're probably watching this as a recording, so put me on 2x speed, replay portions, do whatever you want. But these are going to be the things that we're going to be covering today. So as you can see, a lot of it is Resp heavy, and probably the most important parts of the matrix as it is quite big. But then also you've got ENT and Opthal. These are screenshots from the matrix last year, so I'm assuming everything is the same and nothing has changed. And if that's the case, then we're pretty much covering everything today, apart from a few conditions, because they either, just for the interest of time and because they don't really come up in exams as often. So yes, I'll be going through especially the respiratory portions in terms of presentations. So a good way to think about how to approach a certain presentation, the differentials you would consider and whatnot. Sorry, just a morning matcha, but anyway, moving on. The first presentation we'll talk about is Stridor, and there's a lot of differentials. The main one being croup, but there's also some extra ones that unfortunately aren't in the matrix, but they are examinable, either as they present it as like an option in a multiple choice, or they'll put some buzzwords and you're supposed to kind of know what they are. So we'll go through everything and everything that you need to know for the exam. But the first one is croup. So it's an infection of the larynx, trachea and bronchi, so your voice box region. And it's mostly caused by parainfluenza virus. That's a really important thing to note and very an examinable point. And it commonly occurs in 6 months to 6 years of age with a peak of 2 years. So two things you need to remember: croup 6 and 6, and it's caused by parainfluenza virus. Basically what happens is, because you've got a virus, the airways kind of get inflamed and they cause a lot of secretions. And if you remember to physics, a decrease in the diameter in a circle really increases the resistance. So in an infant or a baby, this is even more pronounced because the airways are already very small, as you can see here, compared to an adult. So because it's so narrow and so small, you kind of get that characteristic seal-like cough, and you also get that stridor as well because of the air going in and out. Typically how it presents, they'll have like a viral prodrome, so lethargy, they've got some coryza, watery eyes, runny nose, and then they've got the cough, and then they present with a stridor, increased local breathing, that sort of thing. And then they typically get better, but they can have the cough go on for a little bit longer as well. The main thing when you get a child that comes in with stridor, and this barking cough and you think it's croup, it's really important that you don't examine the throat. So you don't want to get them to open their mouth, put a tongue depressor in, look inside and aggravate them or do all that sort of stuff, just because it can cause more inflammation and more secretions. And the last thing you'd want is for this to completely close over. So the main thing you want to do is you don't want to examine. There's a lot of different severities, obviously, of croup: mild, moderate, and severe. You don't need to memorize this. You just need to get the general gist. So if it's mild, they're pretty much chilling. They're pretty much, there's no increased work of breathing, really. They've just got the cough. Whereas severe, the child is quite upset, they've got high rest rate, they've got increased work of breathing. And something to note is that hypoxia is a late sign. So if you put the pulse oximeter on the child and they already have low O2 sats, then you're probably thinking this is in severe stage and you really need to escalate this quickly, because if that airway closes over, you'd be going through the basic life support pathway. In terms of management, the main things that you need to know that it's steroids and adrenaline. So obviously before that, before you get to the drugs, you want to initiate supportive management as you would for any viral illness. So, you want to not handle the child too much, because, if they're crying a lot, that can make their airway even smaller and they can get, more agitated. Supportive management like Panadol, make sure that they're well hydrated, that they're feeding. If their saturations are low, then you can consider oxygen. In terms of drugs, it's steroids and adrenaline. And depending on if it's mild, moderate, severe, there's some different things that you do. So if it's mild or moderate, then you just give steroids, so Dex or Pred. But if it's severe, And then you want to give steroids and nebulized adrenaline just to open up the airways. And you want to observe them for a little bit. And you can discharge them depending on what medication that you've given and if they're stridor free. So if they're stridor free at rest and it's been 4 hours post they had the adrenaline and they're chilling, then they can go home. But if they had mild or moderate illness and they're stridor free and they've already had 30 minutes for the steroids to work, then they're safe to go home. But yeah, that's pretty much croup. So croup, main things to remember, it's caused by parainfluenza virus, 6 and 6. You give them steroids and adrenaline. Next is bacterial tracheitis, which this is not on the matrix, but a way that I remember it is toxic croup. So basically what happens in croup, if you don't treat it as well, croup caused by a viral infection, obviously. And sometimes if you don't treat it as well, or if it progresses, you can get a super infection on top of that, so bacterial. And so the child is going to be very febrile, they're going to be really systemically unwell, and it's mainly caused by Staph aureus. So unlike parainfluenza, this is caused by bacteria Staph aureus. Basically, it's worse croup, so secretions are even thicker. They can decline really quickly. Yeah, as you can see here, the symptoms are basically the same as croup, but worse. They don't respond to adrenaline, mainly because the secretions are so thick. You want to get rid of the bacterial infection. In terms of investigations, you still wouldn't want to mess around with the throat too much, but you do want to do like a chest x-ray or even a neck just to see what's going on there. So you can see something called the steeple sign. So this is what the steeple sign looks like. You can see this looks like a church steeple, and this is like the larynx and the going to the trachea now. And you can see here that is like really swollen and really closed over. And so the main management is you want to secure the airway. So you may even consider calling anesthetics to help you do that, and then give them some antibiotics, so IV Kef, to basically treat the bacterial infection. So that's bacterial tracheitis. Just think toxic croup, so an unwell child not responding to the steroids and adrenaline. Next is epiglottitis, which is a Hib infection. This occurs mostly in children under 2 years because they can't mount a T-cell response, so they can't really fight off the infection. And obviously also occurs in unvaccinated or immunocompromised children. The Hib infection, from memory, I think it's given at 2, 4, 6, and 18 months. So any child in Australia who follows the vaccination schedule should be covered for this. You don't really see this as often. So children who are not born in Australia and who didn't necessarily get the national vaccine schedule may be at risk of this. The main things to remember about epiglottitis that it presents with the 3 Ds, so drooling, dysphagia, and distress. So if the child is drooling, they're really like upset, and then the parents are saying that they're not eating, they don't really swallow things as well, then you'd be thinking about epiglottitis. Some other things that can happen is it can have a muffled voice, obviously, because this is the larynx here, and then you have the epiglottis up here. That's a normal epiglottis, and obviously in epiglottitis it's inflamed, so it looks really thick. So obviously as air kind of passes in and out through your voice box, your voice can be muffled. You get hyperextension of the neck, because here this is a lateral x-ray of the neck, and this, as an aside, is called the thumbprint sign. So you can see this is the trachea, or going down to your voice box down here. This is the esophagus. This is the epiglottis. You can see it's extremely swollen. It looks like someone's just like put their thumb on the side there. So that's what's called the thumbprint sign. Anyway, that was an aside. The reason why you get hyperextension of the neck is because if you bend your neck towards like this way, if you bend your head back, you're relieving all that pressure around the front, so it can actually relieve some of the pain. But in terms of management, same things as like croup. You kind of want to make sure the airway is secure, call anos if needed, and you also want to reduce the swelling. So treat the bacterial infection with ceftriaxone and also give them steroids to reduce inflammation. But then you also want to report this to the Department of Health because Hib's a notifiable disease. So that is epiglottitis. 3 Ds, remember that. Next, another cause of stridor is an inhaled foreign body. This is really important, especially in really young kids, and especially if the parents don't really recall a history of seeing the child kind of eat anything or choke on anything. It's still important to consider this in any child, especially under 5 who presents with stridor, because it's extremely common. Obviously, kind of more common in the right main bronchus because of the anatomy, most common with food. You get, apart from the stridor, obviously coughing, choking, vomiting. But the way that children can present is either they have an effective cough or an ineffective cough. So they either can cough or they can't. And some investigations you want to consider is potentially a chest x-ray, just to see what they have ingested. So sometimes you can see bits of Lego, sometimes it'll be food, but it can also be even more damaging things such as button batteries. So that's just something to consider. And in terms of management, it really depends on if they can or can't cough. If they can cough, you want to encourage them to cough because you want them to basically cough it out. But if they can't cough, you would be escalating this to anos again to see if you need to secure the airway. If they're unresponsive, you're basically following the basic life support pathway. But if they are conscious, then you want to give the 5 back blows and 5 thrusts. So it's basically first aid. So back blows, if you did your first aid course, you basically lie the child onto the tummy. Especially if they're a baby, you can kind of just lie them onto their hand and you give the back blows as if it's like an airplane taking off. So you go in an upwards motion, basically trying to push the foreign body out of the airway. So after you give 5 of the back blows, you want to give them thrusts as well. And depending on the age of the child, you either give them chest thrusts. So if they're under 1, you give them chest thrusts. You want to use 2 fingers and just like push onto their chest. But if they're over 1, you can push onto their abdomen. And basically, you're just trying to get the foreign body out. Last cause of stridor that I'll go through is laryngomalacia. Basically, this is a congenital floppy larynx. Obviously, when children are born, they're very soft and very malleable. They don't have very many supporting structures, and that can happen with their larynx as well. So this is a normal larynx, and here is laryngomalacia. You can see as the child will breathe in, the larynx kind of folds over and flops over, but when they breathe out, it goes back to normal. So this can cause not only stridor, but just generally noisy breathing, and it's a common complaint. The main symptom, yes, is positional stridor. So usually this is worse when they eat, they're crying, they're like stressed, aggravated, or they're sleeping, but it goes away when they're in their stomach because they've got more support when they do that around the larynx. Sometimes can also cause some other systemic symptoms. So they might have difficulty eating, so poor weight gain. They may have episodes of apnea and cyanosis, and they also might have GORD or like refluxy sort of symptoms. Usually it's a clinical diagnosis, but for some reason, if they get a laryngoscope down there, you can get something called the omega sign, which is basically this. You can see how the larynx kind of looks like an omega sign, but it's very rare that they'd get that. Management is mostly just counseling the parents and just saying that this is, quite common, and they'll grow out of it with age. As they grow up, they'll kind of get the more supporting structures. They'll get more control over the muscles in that area. But yeah, that's pretty much all you need to know about it. Sorry, that wasn't the last one. There's also subglottic stenosis, which is, it's in the name, stenosis of the glottis, so a narrowing of the area below the glottis, which is around here. It can be caused by, you can either be born with it, or it can be acquired, mainly if the children have had like stuff like ventilations or intubations, especially just because if they've had an intubation or repeated intubations, you can really irritate that area over there, and you can kind of get inflammation, but then also scar tissue, which narrows the area there. So that, that can cause a stridor, but you can also get recurrent infection as well, because that area of tissue is quite susceptible. But that's one of the reasons why when you ask parents if they've had previous NICU times, if they needed oxygen support, airway support, that's kind of the one things that you're kind of considering, because if they have, then you're like, oh, maybe they've got subglottic stenosis. In terms of management though, it's pretty chill. It's mostly self-limiting with growth. That inflammation will subside over time. Awesome. So that was stridor. I'm going to take a bit of a sip. That was it for the stridor part. We're going to go into Wheeze. Wheeze is a quite big presentation as well. And these are the differentials that you might be considering. The first one is bronchiolitis. This is a really, really big presentation. You'll probably see this if you've done peds already. You've probably seen a lot of this, especially if you're in rotation 3, because it is heading into winter time. If you're heading into pediatrics rotation 4, or even in GP land, you'll be seeing a lot of this because pretty much every child under 1 year old will have bronchiolitis at the moment. Basically an infection of the bronchiole, so really lower down your respiratory tract, mainly caused by viruses, and the main one being RSV. So that's one thing to remember, RSV bronch, you'll see that a lot. It only really occurs in children under 1 year old, and I'll go through a little bit about that later. Risk factors, winter time, sick contacts, the usual. And symptoms, again, you kind of get the viral prodrome of coryza, runny nose, watery eyes, irritability. Then you're going to get this increased work of breathing, poor feeding as a result because they're, working really hard to breathe, and also fever and cough, and obviously that wide wheeze. Investigations are clinical, except sometimes in the hospital you might see them do a viral panel or a nasal swab, I guess just for reassurance, or just for curiosity to see what sort of virus it is. But you can just diagnose this without any kind of investigations. Again, like croup, there's mild, moderate, and severe, and it's the same sort of thing. Mild, they're chilling, and if they're severe, they've got marked increase in work of breathing, a lot high respiratory rate, and they've got like apneic episodes as well. Don't really need to know that in much detail. But in terms of the management, it's all supportive management. So you want to give them small, frequent feeds, especially since, especially if they're still breastfeeding. Breastfeeding is quite taxing, not only on, your heart, but, you need to coordinate your breaths as you're feeding. So if they're already struggling to breathe, usually if they do big feeds, they can really struggle with that. So you want to give them smaller feeds so they're not really exerting themselves as much, but then frequently as well. So they're still, getting the intake that they need for the day. You want to do minimal handling, just, don't want to aggravate them too much. You could also consider superficial nasal suction and saline drops. So, like the drops that you kind of just suction cups that you put into the nostrils, to like suck all the mucus out. Because essentially bronchiolitis, you've just got a lot of mucus, and the mucus is making your airways really narrow. So you want to cut it all out. Saline drops can also make the mucus less viscous, so it's easy for it to come out. Give them oxygen if it's low. Fluid management at 2/3 maintenance because they're sick. I won't go through fluid maintenance in this talk. I think someone else will talk about it, or you can just look it up in your own time, just because it's a big topic in itself. But fluid management and how to calculate fluids is really important. You need to know how to do that for 4th year, and also giving them simple analgesia. Something to note is that bronchodilators is not effective because the child will not have smooth muscle, because obviously bronchodilators, they work on your beta receptors to kind of dilate the airways, but they don't have those receptors yet. So that's not really going to do anything. And like I said, it's not because of any bronchospasm, it's because of mucus. So that really won't do anything anyway. And another thing important with management is also counselling the parents. So telling them the likely trajectory of the illness. So usually bronchiolitis, first 2 days will be fine, but there will be a peak at around day 3 or day 4 where the child is at its worst. Most of the times, parents will bring in their child by the time they're at day 3 or day 4. And then they kind of slowly get better. Their fever goes away. They, resume normal intake, but they can have that cough and the wheeze for up to a month. So just letting them know that that can happen. And then sometimes in high risk groups, you may also consider an antiviral, but that's really rare. All right, so wheeze. There's a lot of different types of things that you consider for a wheeze in a child. We've just gone through bronchiolitis. You know what asthma is. There's something new called viral-induced wheeze, which you probably haven't come across until this year. So it's really important to ascertain the age of the child when they present with a wheeze, because that will lead you down different paths. We've already gone through how bronchiolitis is in children less than 1 year old. Asthma, you'd only really consider that in children over 5, mainly because you can only do spirometry, which is the gold standard test for asthma, reliably in children over 5, because you can imagine getting a child to hold their breath in and then breathe out as fast as they can and holding. It's going to be hard for them to be compliant. Even I'd argue as a 5-year-old, I wouldn't do that. I'd be quite upset. So that's why you can't really diagnose it less than 5, because you can't really do that reliably. So there's an in-between, which is a viral-induced wheeze. So that's pretty much in between bronch and in between asthma, preschool age, so between 1 to 5. And the difference between viral-induced wheeze and I guess the two is that if you remember bronchiolitis, the pathophys is basically mucus plugging. Asthma is bronchoconstriction. You can think of viral-induced wheeze as an in-between. It can either be due to the mucus plugging or bronchoconstriction. So bronchiolitis, SABAs won't work, mainly because the no smooth muscle receptors, but also it's not because of bronchospasm. Viral-induced wheeze, sometimes a SABA will work. So that's kind of like the spectrum. Just think it's like, depending on the age, we'll be like, oh, if they're 4 years old, then they could potentially have a viral-induced wheeze or maybe even asthma. But yeah, that's just like the main point I wanted to bring across on this slide. So those are the 3 things that you need to think about. Anyway, moving on to asthma. This is asthma as it is in adults. Asthma is a really big condition in 4th year because mainly it comes on under GP as well. We had an asthma OSCE last year, and it was basically counselling on medications and preventers and how to use them and how to check compliance, that sort of thing. So really important that you know asthma really well. All this sort of stuff is the same as it is for normal asthma, viral-induced wheeze. I already kind of went through. Main things that you want to ascertain when you take a history, though, is kind of when the asthma happens and also the pattern of it. So you can get intermittent asthma or persistent asthma, and that basically depends on if they've got symptoms in between flares and also how frequent their flares are. And also in the history, you want to get if they already have a past history of asthma, the control of it. So do they have daytime symptoms? Do they need their reliever like every single day, or do they need their Ventolin only like less than 2 days a week? Do they have any impacts on their activity and any impacts in their sleep? So they're the things that you kind of want to ask in history. Obviously as well, like, all the other conditions as mild, moderate, and severe, you don't really need to know this. It's pretty self-explanatory. But management is really important. This is probably one of the conditions in management where you really need to be around it because, like I said, this has come up in an OSCE. It has come up in OSCEs for a few years now, and also it's very examinable in the written. So would pay attention to management especially. For an acute flare, obviously doing your doctor's ABCD, minimal handling, sit them up right, give them oxygen if they need it. But the main thing is this burst therapy. And the burst therapy is similar as it was in an adult, except it depends if it's mild, moderate, and severe, and depends on the age as well, because it will change what you do. If it's mild asthma, you just give them, they need a reliever, essentially. They need to have the airways open. So if they're less than 6, you give them 6 puffs of Ventolin. If they're over 6, you give them 12 puffs. And then you reassess them after 20 minutes, see if it's worked. If it hasn't worked, then you give them another round. If it's a moderate asthma, then it's almost the same as the mild, except you also give them ipratropium and you also consider steroids. So if they're less than 6, it's 6 puffs salbutamol, 4 puffs ipratropium, and then you may consider steroids. If they're over 6, it's 12 puffs and 8 puffs, and then you also give them steroids. For both of these, you want to reassess them after the 3rd dose. So you do a burst for an hour. So you do the 6 and 4, 12 and 8 every 20 minutes for 3 doses. After an hour, you see if it's worked. If it hasn't worked, then you do that burst therapy again. And then if it's severe, you essentially do the same as moderate, except you add mag sulfur aminophylline, which basically also act to dilate the airways. Next, after that, you want to essentially stretch the burst because they can't be on burst therapy forever. So after, you recess after the hour, if they are fine, can they go without the burst therapy for an hour? Can they go without it for 2 hours? Can they go without it for 3 hours? And if they're reaching that 3-hour stretch mark, they're safe to go home. But before they go home, it's really important that one, you educate the parents, you educate the child on what asthma is if they're a new diagnosis. You give them an asthma action plan so they can give it to their school or their daycare. So whoever is looking after them there knows what to do. You want to make sure that you review the inhaler technique, so how you coordinate the puffs, how many puffs, how to use a spacer, how to clean the spacer. You also want to arrange a GP follow-up as well. Just with the inhaler technique, good idea to kind of get your language, get your lingo around of how you'd explain that to a parent, because that was OSCE last year. Awesome. So chronic management as well. This is more stepping into GP territory, but essentially it's following the asthma ladders that you see on like the Asthma Australia Council guidelines. There is 2 different age groups between 1 to 5, 6 to 11. Anyone over the age of 11, 12, they follow the adult ladder. And essentially, they're pretty much the same, as you can see. I put them side by side, so it's easy for you to compare. But the first rung is they need a reliever, they need a Ventolin. Everyone does. Everyone needs that if they've got asthma. Next step is you want a regular preventer. Then the next step above that is you want a higher dose or even more stronger preventer. The regular preventer is usually just a steroid, and then the step up is a higher dose of the steroid. But the main difference is that as you kind of get older, you kind of can use an Ix-LABA combination. So those are things like Symbicort, like the Symbicort Turbihaler, that's like a really common one, or even the Ellipta, which you can see in COPD. Because if you remember, the adult ladder is basically SABA is the first rung, then you have the second rung and third rung being Ix-LABA combination, so Ix-LABA low dose, Ix-LABA medium dose, Ix-LABA high dose, and the fourth rung being specialist input, as it is here as well. But in children, usually you just do inhaled steroid first before you do the Ix-LABA, and only Ix-LABA if it's 6 to 11 years old. An example of an inhaled steroid that you might see on the wards is fluticasone, so the purple inhaler, and that's very common. So that's a preventer that most children will use. Awesome. That is asthma. Next is cystic fibrosis. This is also, this is examinable. This is examinable content. And last year they were very specific. So they gave us, one of the questions I remember were, what's the incidence of cystic fibrosis? And the options were like 1 in 25, 1 in 250, 1 in 2,500, and 1 in 25,000. So, you know, it's relatively something that you need to know kind of well. But in terms of etiology, I probably remember from pre-clin, or if you did biomed, this is very biomed heavy, but it's an autosomal recessive mutation of the CFTR gene. Essentially, you get defective chloride channels, and that makes the mucus in your airways, the normal mucus in your airways, a lot thicker than usual. It can cause some plugging. But cystic fibrosis not only happens in the airways, it can also happen in other parts of the body, any part that has like a lumen, basically. So your gut, your lungs, your sex organs, that sort of thing. So depending on the age of the child, they can present with a lot of different things. During infancy, it's mainly to do with growth and your gut sort of stuff. As you head into adolescence, you can not only get the respiratory symptoms, but you also consider things about like your sex organs and fertility and stuff like that. So just things to consider. In terms of investigations, a lot of the time, all children born in Australia will get a heel prick test, and that's pretty much done in day 2 or day 3 of life. And it tests for 4 different things. So cystic fibrosis is one of them, but hypothyroidism, congenital adrenal hyperplasia, and fetal ketonuria all tested on the heel prick test. So any child born in Australia, you should be able to pick up cystic fibrosis pretty easily, and you should be able to initiate management pretty early. Other things that you might consider is like a sweat test, DNA testing as well, especially if both parents might be carriers, and you can do your Punnett squares, and then imaging, so chest x-ray if you're worried about the respiratory symptoms. Management, you don't really need to worry about as much. You just need to know it's you need a multidisciplinary care team, and you need to address a lot of the different things, or a lot of the different symptoms that cystic fibrosis can cause. So respiratory, nutritional, and also the psychological aspect of it. You don't really need to know it that well, though. It's a bit hard to examine. Awesome. So next, going on to cough. These are the differentials that you'd be considering for cough. First one is pneumonia, pretty much like adult pneumonia. Most of the time in children, it's a combination of viral and bacterial. But if you're thinking about a bacterial cause, depending on the age of the child, there can be different things. So if they're less than 2 months, mainly the main things you'd be considering is GBS, just because it's, especially if they're born through a vaginal birth, a lot of the bugs can be from the mother's perineal flora. But if they're over 2 months, not only is viral the most common, but you can also get things like strep pneum, Staph aureus, gas, that sort of thing. But yeah, you can see here, these are probably reminiscent of the third year matrix in pneumonia, pretty much the same. Investigations, mostly clinical, but you can also do like your sputum cultures, nasal swabs, inflammatory markers, infection screen, that sort of thing. The main thing though is that you don't chest x-ray everyone like you do in like an adult, just because radiation exposure, you really want to limit that in a child. So you basically don't want to image them unless you really need to. And in this case, for pneumonia, if you think it's pneumonia and you treat it, but they haven't improved after 2 or 3 days, then you probably want to image that. Or if you've got really severe pneumonia, you kind of want to pinpoint where it is, or if it's like a complicated pneumonia. And in terms of management, supportive, but then also antibiotics. The antibiotics is sort of similar to adults in that you've got your ABC rules, so mild, moderate, severe, amoxicillin, benpen, and kef. That being the ABC, but it's slightly different. So mild is still amoxicillin, moderate, it's amoxicillin or benpen, and then severe, it's still ceftriaxone, but then you also would add fluclox as well, because the little babies or their little children, their immune system is not as fully developed. So you kind of want to give them, you want to make sure that they clear their infection. Another cause of cough is whooping cough. You need to know that it's caused by bordetella pertussis. That is very examinable. And risk factors are, not vaccinated, because that is a vaccine preventable disease. Sick contacts if they're less than 6 months. The interesting thing about whooping cough is that it comes in 3 stages. The first stage is called the catarrhal stage. So that's where you get basically your viral prodrome as per any other viral illness. You get your coryza, cough, runny nose, that sort of thing. Then you kind of get this paroxysmal stage, which is stage 2. And this is characterized by the whooping cough. So that inspiratory whoop when you cough, but you also get coughing fits. So, you can go through periods of time where you're fine, but then all of a sudden you've got a massive coughing fit. You can't stop coughing. And sometimes the coughing is so strong that you can kind of vomit afterwards. So I think I've seen in a practice question, it was like, oh, this little child is brought in by their parents and they're complaining of vomits after coughing. What do you think it is? And it was whooping cough. So that's kind of how it can present. And then the third stage is the convalescent stage. So essentially the cough can last up to 3 months afterwards. A more colloquial name for whooping cough is the 100-day cough. And it's because of this third stage. After they get better and they're systemically well, they can just have like a post-viral cough, or not viral because this is a virus, but they can just have a viral cough, a really long cough afterwards, even though they're recovered. And that's something that you need to counsel the parents about. In terms of management, you want to, if they're really young, you want to admit them to hospital because it's life-threatening. You want to isolate them because obviously they're infectious in this stage. So especially since this is a notifiable disease, you don't want to spread it around. How long you isolate for depends on if you are on antibiotics or if you aren't. So if they're on antibiotics and they've been on it for 5 days, you're, sure enough that the antibiotics would have covered them sufficiently so they can go out and explore the world. If they aren't on antibiotics, if they've had the cough for at least 3 weeks, they should be fine, mainly because you've passed that infectious period, and they'll be coughing for ages. So they're not going to be infectious for that whole time, but the first 3 weeks are probably the most infectious. Report to Department of Health because it's notifiable, and you want to give them antibiotics, especially if they're in stage 1 or stage 2, because that's kind of the only way you can get rid of this bacteria. And obviously make sure that they're vaccinated, prevent it. But this is part of the normal vaccine schedule, and I'm pretty sure it's also at months 2, 4, and 6, but you'd have to double check that. I'm not too sure. Awesome. So that's respiratory. Go take a break, do whatever, and then come back, have a drink, have a sip of your coffee, have a sip of mine. But we're moving on to ENT. With ENT, these are the things that we'll be covering. Some of this is actually considered rest, but it fits more into ENT, I think, in this scenario. First one is allergic rhinitis or hay fever. This sucks. I have it, but you can get different types. So seasonal during certain seasons, most time during the springtime, or you can get perennial, which is perennial, and it's usually due to allergens such as dust mites or house mites. It is it's one of the atopic triad. Pathophys is a type 1 hypersensitivity reaction. So you get degranulation of the mast cells after a sensitization event. In terms of symptoms, you're thinking like runny nose, watery eyes, sneezing, coughing, itchy throat, itchy skin, that sort of thing. If you were to examine the patient, this is a picture of the nasal terminate. So if you use an otoscope and you kind of look up the nose, you can see it's quite red and swollen. If you look into their throat, their pharynx is cobblestone. You can see here that this is the Denny Morgan lines or allergic shiner. So this line underneath the eye is called the Denny Morgan line, and that just indicates there's a lot of edema. So you can see that the eyes are quite swollen and puffy. And then you can't really see it here well, but I think this is trying to show that allergic shiner. So their under eyes can be quite shiny. That's due to just, again, the edema. You can also get a nasal crease as well because, they rub their nose so often, they're pushing their nose up. But I haven't really seen that in real life. So I'm not sure if that's true, but that's something that you can examine on exam. In terms of investigations, it's mostly clinical, but you can do a skin prick test just to, figure out what the allergen or what the triggering event is. But in terms of management, obviously you've got non-pharm and pharmacological. Non-pharm, you want to avoid what's making you sneeze and cough and do all that, obviously. And then also you want to consider a nasal irrigation, so like saline flushes where you kind of flush salty water up your nose and clear your sinuses that way. Pharmacological, just probably need to just know it's antihistamines or steroids. It depends if it's mild or moderate severe. If it's mild, you can just use an oral antihistamine. If it's moderate to severe, you can consider things a combination of antihistamines and intranasal corticosteroids. Nasonex is an intranasal corticosteroid, so you can do an oral antihistamine and some Nasonex. If it's really bad, you can get things like Demister, which is essentially an antihistamine and steroid just in a nasal spray. If you have hay fever, this works wonders. Would highly recommend. It's no longer a prescription medication. You can just get it over the counter. So no scripts need to be filled for parents or patients with hay fever for this. There's some other things that you might want to consider. So if they've got really runny nose, you can give them ipratropium intranasally. You can consider decongestants, but not for really young children. So not for children under 6, and you don't want to use it for more than 3 days. So things like Otrivin, I'm not sure if any of you have heard of it or used it. It works wonders, but you don't want to use it too often because you can get something like a rebound congestion, basically. So it will work really well for the first few days, but then it will stop working. So you want to kind of give it to yourself in bursts and not for prolonged periods of time. If they've got watery eyes, you can consider eye drops, antihistamine eye drops. And then if they've got asthma, montelukast actually helps as well. And then the last line being immunotherapy, but you need a referral for that. Awesome. So next one is OSA. OSA also happens in children. It's not just an adult disease, but the causes for OSA is a little bit different. The main one being adenoid hypertrophy. That's the most common. But you can also get things like obesity, which is the same as in adults, but then also Down syndrome and cerebral palsy. So Down syndrome, a very common thing, a common characteristic in Down syndrome is they've got an enlarged tongue, and because their tongue's so enlarged, sometimes it can close over their throat. And with cerebral palsy, because you've got a reduced control of your motor function, they can't really control the muscles around the neck as well, so it can really close over easily. It presents as, obviously snoring, but snoring in childhood is common and OSA is not. So just because a parent brings in their child with complaints of snoring doesn't necessarily mean they've got OSA. Peak incidence is around 2 to 7 years because a lot of their lymphoid tissue will start growing bigger, and especially in the adenoid. So if the adenoid hypertrophy in the next slide, especially if your adenoids, if this is growing bigger, it can really close over your throat really easily. In terms of examinations, you want to check the neck circumference, but especially for adenoid hypertrophy, you want to look for the characteristic signs of adenoid facies. So this is what this picture here kind of is showing. It shows the Denny Morgan lines, allergic shiner, nasal crease, as it was for allergic rhinitis, but then you also kind of have a lower recessed jaw. They've got mid-face hyperplasia, so their mid-face sort of looks a bit larger and then kind of like a smaller jaw, and that's just consequences of essentially being a mouth breather, and so you can have because they're so young, they can have changed anatomy. This is actually a lot more common than you think it is. I saw this a lot in GP, not so much on the wards in peds. So if you're going into GP next, and especially during the winter time, you might see a lot of this and a lot of complaints of this snoring. So that's something that you should consider. Investigations, you can do the screening tools. You can also potentially give them a pulse oximeter overnight. And if it shows a reduced sats, then you probably want to book them in for a sleep study. But essentially, the management for OSA is treat the cause. So if they have, if they're a bit overweight, you want them to lose weight. If they've got adenoid hypertrophy, you want to remove the tonsils, you know, that sort of thing. And then last line being CPAP if it's really bad. Awesome. So sore throat's actually quite a large condition, and it's a lot of, you know, it's really important to know this really well. It's quite common. Etiology, like most things, mostly viral, but it can also be bacterial. And with bacterial, the main things that you're worried about is group A streptococcus, so things like strep pyogenes, because you can get things like acute rheumatic fever, rheumatic heart disease as a complication if you don't treat strep throat properly. So risk factors, that's why here it's a red flag: past history or family history of acute rheumatic fever, rheumatic heart disease, or Indigenous Australians, just because they're more at risk of having this group A strep. And you want to make sure that that's treated appropriately to prevent these complications that are listed here. So non-suppurative being, you know, your scarlet fever, acute rheumatic fever, rheumatic heart disease, and then suppurative complications as well. So main one being quinsy. So this here is a quinsy. So firstly, before we go into quinsy, there's different types of, you know, severity of tonsillitis. And if you want to look really flash and you look like you know what you're talking about, you can grade them on a scale of 1 to 4. Easiest way to remember this is grade 1 is essentially normal. Grade 4, tonsils are kissing, and grade 2 and 3, it's somewhere in between. And you can see here, like that's the tonsils here kind of enlarging. With a quinsy, it's a peritonsillar abscess. So it's before the tonsils and there's an abscess kind of before it. You can see here, this is a picture. So this is a slide on the complications of a sore throat, but this is the quinsy. So you can see that's the tonsil here, but there's this massive abscess beforehand. And it's essentially, if you have tonsillitis and you don't treat it, it can spread and cause a quinsy. And you can get drooling, dysphagia, you get a muffled hot potato voice. That's a buzzword characteristic. And you can also get trismus, so they can have painful jaw or even a locking jaw. And you can see here the uvula is deviated because that abscess is so big. Main management for a quinsy is you want to refer this to ENT because you need to drain this. You need IND, so an incision and drainage. You want to give them some Benpen as well because it's an infection, it's an abscess. You need to treat it. Another thing that can happen is the infection can spread to the back of the pharynx, so a retropharyngeal abscess. And you can, you know, if on examination, if you feel around the neck, they'll be quite tender and sore, and you can feel like a fluctuant mass. They can also have torticollis, which is essentially like a muscle contraction, an abnormal muscle contraction, because the abscess is very painful. And you can see here on a lateral neck X-ray, you can see a semicircle opacity over here, and that's the abscess like behind the pharynx here. And management, again, you want to refer this to ENT, and then you also want to give them some hard-hitting antis. And then this is a non-suppurative complication, scarlet fever. So especially for strep throat, you can have exotoxins, and that essentially can spread. You can have a widespread infection. So they'll have obviously fever because it's in the name, scarlet fever, but they have this characteristic sandpaper-like blanching rash. It's usually 2 days after the fever, and it's located kind of like on the top half of the body. And usually after 3 or 4 days, it will like desquamate. So you'll have skin peeling. But then also other buzzwords to know is a strawberry tongue and circumoral pallor. So you can see around the mouth, it's quite wide. So strawberry tongue, things to think about is Kawasaki disease and also scarlet fever, especially if they've got a desquamating rash. Awesome. So in terms of symptoms, it's pretty self-explanatory. Sore throat, difficulty swallowing, pain on swallowing. The red flags you want to screen for the trismus, hot potato voice, and neck stiffness, all because of the previous complications that we've talked about. Something that you should probably know is the central criteria for sore throat, and this is basically to rule in or rule out strep throat. So the good thing about the name Centaur is that it's an acronym. So C stands for cough absent, E is for exudate present, so exudate on the tonsils, and if you've got lymphadenopathy, T if they've got a temperature, and then or for like young or old. So if they're young, they add 1 point. So if they've got 3 points or more, then you would be really thinking it's a bacterial cause or strep throat. So you want to do an ASALT titer and a culture. If it's 2 points, then you might consider ASALT titer and a culture, and if it's 1 point, then it's not bacterial. So those are some things that you probably want to ask about or examine for in your history. And other things in terms of investigations, because it can also be viral for the sore throat, you might be thinking about EBV, so things like FBE, monospot, and serology. In terms of management, the main things are you want to reduce the swelling and kind of get the patient more comfortable. So if it's bacterial, especially if it's a group A strep, you want to give them some antibiotics. So if it's gas or if it's any other kind of bacteria, you want to give them phenoxymethylpenicillin. But if it's a quinsy, you give them stronger antibiotics. But the main thing is if they do require antibiotics and if they're a high risk group, so that being if they've got a past history of, the rheumatic fever, rheumatic heart disease, or if they're indigenous, you want to give them some antibiotics because you don't want them to kind of develop those complications as before. So it's phenoxymethylpenicillin. Just remember that. Sore throat, phenoxymethylpenicillin. You also want to give them steroids as well, especially if they're not responsive to simple analgesia such as Panadol, so like dexamethasone, just to reduce the swelling there and to help them eat and tolerate oral intake. And then quinsy we already went through about, and then if their tonsils are large, you can get them removed, but the main thing is there's this thing called the Paediatric criteria. You don't need to know it, but it's really not very many people qualify for it. It's something ridiculous, like you need to have like 7 bouts of tonsillitis in a year for you to qualify. So bottom line is that it's very hard to kind of qualify for this. Awesome. So ear infection, middle ear infection, very common in young kids, especially because of their ear anatomy. Their eustachian tube is a lot more flat rather than vertical, so it's really hard to drain any infections out. But most of the time, these ear infections, again, are viral, not bacterial. But if they are bacterial, it can be a range of different causes. There's a lot of different complications for ear infection, main one being perforation, but actually when the eardrum perforates, the pain is relieved because obviously all that pressure behind the ear and all that fluid is quite painful, but as soon as it perforates, all that pressure is relieved and everything can drain and the child's actually much happier. You have things like acute mastoiditis, so and it spread to infection to the mastoid bone. That's why when you do an ear exam, you kind of feel for tenderness around the mastoid area, so like post-auricular, see if it's warm, hot to touch. If it is, and you think it is, you need to refer them to ENT. You want to do a CT imaging because you want to see the actual mastoid bone and see if it's been eroded. You also want to give them some hard-hitting antis. And then the next 3, so ohm, comb, and cysome, are also complications of an ear infection. Basically, you can have ohm is an ear infection with fluid behind the ear, and it lasts usually for more than 4 weeks, but they're not febrile or anything for those whole 4 weeks. They'll just kind of have that sensation of ear fullness and kind of difficulties hearing, but usually it will go away by itself by 3 months. Then you can have basically the same thing except chronic. And so that's basically ohm for more than 3 months. And those children will need grommets. So grommets are like little tubes essentially that gets put into the eardrum and allows the fluid to drain on its own because it's been there for more than 3 months. You don't want any infection seeding in there. And you want to kind of relieve the pressure because it's quite painful. And so the grommets will be put in there by an ENT surgeon and they'll kind of drain the fluid, and the grommets will fall out on their own. So they'll just come out on their own. You don't need it removed. And then chronic suppurative otitis media is basically a chronic ear infection and a perforation. And so because it's perforated, you kind of get this mucopurulent discharge, and it usually happens for more than 6 weeks. It's painless because it's perforated. But main things is you want to dry oral toilet. So like a rolled up bit of tissue, and you kind of just want to like dab on the discharge that's coming out of the ear, and you also want to give them some antibiotics. That's acute mastoiditis. So that's like the mastoid area. Obviously, it's very red. This is a perforation of the eardrum. So this could be a cysome. I don't really know how to pronounce that, but chronic suppurative otitis media. You can see that the tympanic membrane is extremely opaque, but there's a hole in it. You can see that creamy white discharge. This picture here is just showing you, this is what a normal eardrum looks like. That's some bubbles behind the eardrum, and this is a full effusion. And then this is a normal eardrum. When you're doing an otoscope, especially in GP, if you want to look all like hip and flash and you know what you're talking about, there's some things that you kind of want to report on. So obviously you want to see if the ear canal, one, if there's any foreign bodies in it, if you've got any wax impaction, if it's red around the walls, but then you also want to comment on the actual eardrum and middle ear itself. So is the tympanic membrane opaque? Is it translucent? And then is the cone of light reflex present? So this is what the cone of light reflex is. Depending on which ear you look at, can be either at the 7 o'clock position or 5 o'clock position, but that's not really important. But essentially the cone of light just says that, you know, your tympanic membrane is taut and it's also translucent. So it's just something that you can comment on. And in terms of symptoms, obviously ear pain, if they're a young child, it's going to be hard for them to comment on ear pain. So sometimes you can, you know, see them tugging or pulling on their ear and they're very irritable. In terms of management, mostly it's supportive because most of the time it's viral, but you can give them antibiotics if they haven't improved after 2 days or if they're part of the red flag group. So you can see here, this is taken from the RCH website, but there's a group of individuals who would need immediate antibiotics, those being young children because they're really susceptible to really nasty diseases, Indigenous people, immunocompromised people, and then children with only one hearing ear, because obviously you don't want their good ear to be bad, otherwise they won't be able to hear anymore. But yeah, this is kind of like the management plan, and it's just augmented BD for 5 days. Awesome. So we're almost done, ophthalmology, and then we're pretty much done. You're doing really well, so take a break, do whatever you need. But we'll start off with orbital and periorbital cellulitis. This is an image of what the differences are. So periorbital is also known as preseptal cellulitis. So this here is the orbital septum, and it's pretty much kind of where the orbit is, and it kind of separates before and after. Before and behind the eye. So periorbital cellulitis is an infection before the orbital septum, so preceptor, and it's very superficial. You can see here it has no involvement with the eye at all, whereas orbital cellulitis is behind the orbital septum and it really involves the eye area. And so when we go into the next slide and talk about symptoms, it will really make sense as to why patients present the way they present, and why when you do the examinations, you can elicit some certain signs that are favorable to either orbital or periorbital. You can see this poor child here has a really swollen eye, and it probably looks like he's got an orbital cellulitis here. I put it in a table so it's easy to compare the two, but we've already talked about the pathophys. In terms of the etiology for both, it's mainly either an infection spread, so either you've had a cut around your face and that infection has spread to around the eye area, or it can be infections from your sinuses, your conjunctiva, and it can spread that way, or trauma. So if you like have an eye punch or something, you can get like foreign bodies or even like a laceration to that area. Something to note for orbital cellulitis, sinusitis is probably the most common cause, and the ethmoid bone is the most common because it's quite porous, so the infection is easier to spread. But in terms of symptoms, they both present with that unilateral kind of red swollen eye. It's quite tender, but when you examine, it's really important that you assess the eye movements. So asking them to do the H movement and see if they have double vision when they do that, or if it's painful, because if it is, that's pointing you towards orbital cellulitis, because it's behind the eye. Infection involves the orbit, so movements and stuff like that will be really painful. In terms of the complications, it'll be spread of infection for orbital cellulitis because it's further into the eye. It's closer to the brain as well. It's really easy to spread it it's really easy for it to spread to areas where you really don't want it to spread. So it can, go into your brain, and you can have a headache. You can have cavernous sinus thrombosis. And you can also have an abscess, so an abscess behind the eye causing the eye to bulge out. And then obviously visual impairment. So orbital cellulitis is a medical emergency. And the reason why it's a medical emergency is because you can become blind if you're not treated properly. So in terms of management, for periorbital cellulitis, you just need antibiotics, basically. So if it's mild, cefalexin. If it's moderate, you get given something stronger like Fluclox or Kef. And if it's really severe, you manage it as per orbital. And orbital, because it's a medical emergency, you need to escalate this. So admit, refer to ENT and ophthalmology. They potentially also need to fast because they might need surgical intervention. And then you also want to give them some strong antibiotics, so like the Fluclox and Ceftriaxone. And then also manage the underlying disease. So if they've got sinusitis, you want to treat that as well. Awesome. So retinoblastoma, this is an R3. You just need to know it's a tumor of the retina. It occurs mainly as a congenital or inherited thing. So you need to know it's an autosomal dominant inheritance. That's very examinable. So any hereditary diseases, it's probably a good idea to note them down and the inheritance pattern down, because it's very examinable content, and put them on your Anki or write them out on a list and memorize them. So just know that retinoblastoma is autosomal dominant, but it can also be sporadic. So if it's hereditary, if it's that autosomal dominant inheritance, it'll be both eyes, but if it's sporadic, it'll only be one eye. The main symptom is that you get leukocoria on the red light reflex. So as part of the neonatal baby check, you do a red light reflex on every baby. The main thing being to check for retinoblastoma and cataracts. But you can see here in this chart, the leukocoria is an abnormal red light reflex in that you don't get that red kind of light shining back at you. Instead, it's white. So you can see here, this is the abnormal eye and this is the normal eye. I know this doesn't look really that red, but this is not normal. Like, yeah, you shouldn't be seeing this. So once you do see that, you just refer that to ophthalmology and they'll deal with it. Next thing is cataract. Again, it's an autosomal dominant inheritance if it is hereditary, but you can also get it congenitally, mainly due to infections. So some of your torch infections as well. Complication is cataracts. Again, symptom is the same thing as a retinoblastoma, the leukocoria, but then they also can get strabismus or developmental delay because they can't see anything and they can't really play or do that much. Complications, they can get visual loss, and then main thing, you just want to refer them to opt out. That's all you need to know. Last one, so strabismus. So it's also more colloquially known as a squint. So basically it's a misalignment of the eyes. So depending on where the eye is misaligned, it gets different names. So if it's towards the nose, it's esotropia. If it's away from the nose, it's exotropia. Pointing down is hypo and pointing up is hyper. Sometimes the squint or strabismus can be very obvious and you can see it immediately in the chart, but sometimes it's not as obvious. So there's a few tests where you can kind of elicit that, and I'll show you that in the next slide. But the main symptoms are, if it's not as obvious with the squint, is double vision, any trauma to the eye. If they also have an obstetric or developmental history, sometimes that can give you a clue in. But yes, they have, uncoordinated eye movements, they got double vision and that sort of thing. But the main things you want to do is refer them to ophthalmology, like any eye condition. They potentially also need some corrective lenses or eye patching. Fun fact, I had squint when I was younger and I had to wear an eye patch for hours and hours on end. So basically you patch the good eye and you want basically the lazy eye to start working. And once it starts, pulling its weight, it will kind of find its correct alignment. But sometimes it's really bad. You want to go through the surgical route, but that's up to the ophthalmologist's choice. These are the tests for strabismus. You don't need to know this in detail, but it's just for your kind of knowledge and kind of just so you can understand it. But especially because some strabismuses aren't obvious, you want to kind of see if the different tests where you can see if the lines are aligned or not. So the first one is a light reflex test. Basically, if the light isn't shining directly in like the center of the pupil, then you might be thinking, oh, they're misaligned. Same thing with the red light reflex. If it's unequal in size, shape, or color, then you might be thinking the eyes are misaligned. Then there's things called the cover test. So this is the cover test here, and this is the uncover test here. So with the cover test, you want to cover the normal eye. So here, this is the abnormal eye. You want to cover the normal eye. And because the normal eye is covered, the abnormal eye will instantly correct itself. So if you cover it, you'll see the eye kind of move like to the correct area. And then once you remove it, the eye will go back to its kind of former position. The uncover test is a bit different. So the uncover test is you want to cover the abnormal eye. So here the eyes kind of look normal, but you want to cover the abnormal eye. So that being the left one in this case. And once the abnormal eye is covered, it will slowly drift into its kind of like abnormal position. But then when you remove the eye patch, it will immediately correct. So if you see the eye kind of move before and after you cover, then you'd be thinking about the strabismus. But yes, that's all that we've covered through today. I was yapping a lot, so hopefully that all made sense. Hopefully this is helpful. Planning in 2 times speed, I already talk really quickly, so it'll essentially be ×4 speed. Replay certain bits, but if you've got any questions at all, please don't hesitate to send me an email. That was in the first slide, or you can find me on Facebook. I don't mind. But best of luck with 4th year. 4th year is a marathon. It's not a sprint. Give yourself some grace. It's a tough year to get through, but you all get there. At the end of the year, we'll also have a live in-person like MCQ sort of thing. So stay tuned for that. But best of luck for your studies. And yeah, hopefully this is helpful.